So protein energy malnutrition, that's why we're all here and why there's so many of us in the room. With liver disease, studies of the liver transplant waiting list have showed that between 90 and 100% of patients are malnourished. The demographic on the waiting list, or the indication for transplant, has changed slightly in the fact that some of the patients being transplanted for tumours might not be malnourished, but they all end up with some form of supportive nutritional advice. So sarcopenia and sarcopenic obesity is becoming very problematic and is very clinically challenging. I'll talk about that as I go through with anthropometry, and there's a couple of slides on obesity, which is not enough, but again, maybe that's something we can pick up in questions. So cirrhosis is, as we know, split into compensated and decompensated, the difference being that the liver's cirrhotic in both cases, but in decompensated cirrhosis, that's when there's evidence of liver failure and symptoms. So we used to think that muscle loss was confined to decompensated cirrhosis, but we know that in probably 0 to 20%, 20 to 40, it's increased in recent years of patients, that there is evidence of muscle wasting and malnutrition, which can be undetectable because there may be minimal weight loss, and we'll talk about that as we go through. Advancing decompensated cirrhosis, in the general population of chronic liver disease, you're looking at up to 95% of patients. So if you translate that into the people we see in clinic, or the people that are admitted onto the ward with chronic liver disease, you're hard pushed not to see them, because at least 9 out of 10, well, no, at least 6.5, half a patient, out of 10, up to nearly 10 out of 10, are going to have protein energy malnutrition. And this is also important pre and post liver transplantation, as has been mentioned many times this morning, and I'll give you some examples of things as we go through. This slide is not to linger on necessarily, but I think it's a really good example of the patients that we see, what we're trying to prevent, what we're trying to minimize, delay the progression to transplantation. Sometimes people come to transplant early because they're malnourished. If they're not as malnourished, the symptoms are often not so bad, and you can delay the need for transplant. This is highlighting the causes of malnutrition, so we're not just up against someone with a poor intake. We're up against someone with a poor intake, with what they ingest being not digested, not absorbed, or the other metabolic derangements that go on that impair the delivery of energy and protein to the places they need to go. Then you've also got poor intake, which is inherent with the inflammatory cytokines and can cause anorexia. So it's not just someone that's got high requirements and can't eat. The reasons for those are many, and we'll unpick them on these other slides. So why malnutrition? Reduced nutrient intake. Many reasons. We're all familiar with lots of them. Specific to liver patients, I'm going to unpick some of these in the next presentation, but you can have symptoms as nausea, vomiting from ascites, that can also be from malabsorption, delayed gastric emptying, dietary restrictions, which unfortunately we still see, that have contributed to somebody losing muscle or being malnourished. Sometimes they're started by doctors, GPs, but we do get a lot of patients transferred where that's been contributory. Abnormal taste. There's a lot more research into zinc affecting taste, and particularly in the alcoholic liver disease group, which we're starting to unpick. So trace elements and depletion of them can also play a role in appetite and intake. Encephalopathy. You get people with reversed sleep pattern. Now, and you'll see when people come with chronic encephalopathy, they do have this insomnolence. They can't sleep at night, but then they can't keep awake in the day. Well, that's difficult. If you're part of a family, they're eating in the day, you want to eat overnight. And in hospital, it's difficult enough to get adequate nutrition in waking hours, let alone in sleeping ones. So they also get generalized weakness and immobility. That does not make you want to get up prepare food, get yourself something to eat, the effort of eating, what you fancy, all of the things that we hear from patients. And then frequent hospital admissions, repeated investigations. With the best will in the world, they get cancelled, so people can be nil by mouth for various procedures that then don't happen. We used to try, and I think we still do to a degree, maybe, and correct me if I'm wrong, to try and tee up procedures or investigations so that they happen in a short time frame or on the same day. But I think as the hospital's grown, that's become more difficult to organise. We used to try and minimise the length of time nil by mouth. So we can also need to think about malabsorption and protein losses. And again, there's not just one reason for this. So inside our patient that may even be eating well, there are lots of sort of flawed pathways for the absorption and utilisation of nutrients. First and foremost, and this has come to the fore recently, and again, it'll be in the next presentation, but reduced bile secretions, and in Liz's talk earlier, we heard about the liver function test that can reflect that, so the ALK Phos and the bilirubin. But reduced bile secretions into the duodenum reduce the action of bile as an emulsifier. So again, I'll unpick this later, but you can get biliary steatorrhea. There's also pancreatic insufficiency that we see in our patients. Again, I'll unpick that a bit later. We do see a lot of small bowel bacterial overgrowth, repeated antibiotic use, previous transplant with roux loops that have become overgrown. And just because of the altered function of the liver, Kupffer cells suck up sort of dead bacteria on the way through. But if that's defective, then bacteria that reproduce that shouldn't get the opportunity to overproduce and colonize the gut with bacteria that are not helpful. We've also got coexisting conditions, so patients with PSC, primary sclerosing cholangitis, there's a very strong relationship with ulcerative colitis. So a lot of that group have problems with pouchitis and symptoms of UC as well. Then we get drug-related diarrhea. Lots of patients are on lactulose to treat encephalopathy. That can cause wind, bloating, intestinal hurry from other drugs as well. And frequent paracentesis. So even if they're absorbing the nutrients, we're draining off protein when people are paracentesed. So there are a multitude of reasons, even if someone's eating well, why they might not be getting optimal nutrition from what they've consumed. The key thing for me, and that I feel and we treat as pivotal in the patient's management, is the picture of altered metabolism. So it's this altered energy metabolism and lack of glycogen as a substrate that underpins the muscle loss in patients. So as you know, usually in our fed state, we replete our stores of glycogen because the liver metabolizes glucagon. So it will get rid of circulating glucagon, which comes out when we're fasting, to liberate glycogen to turn into glucose. Again, as you know, the primary fuel for the brain is glucose, and that dictates what the other organs get. You can't burn mixed fuels at speed, so you can't burn fat and glucose together concurrently in equal portions. You can use fat mass as a top-up of fuel, hence why we give the advice for weight loss to do it slowly. So if you're in glucose metabolism and if you're eating a mixed diet, you will stay in glucose metabolism. So you can't liberate energy quickly from fats. The net result of this is that between meals, when there is no glycogen, the food has run out after 2 to 3 hours. Then the patient's running on empty. They have their fat mass, which they can't access quickly because they're eating a mixed diet and they're in glucose metabolism. So essentially what that means is that they undergo gluconeogenesis and burn their muscle to create glucose. So short-term fasting results in muscle catabolism, and that will be mid-morning, mid-afternoon, evening, and overnight. So we're getting muscle wasting in the post-absorptive state. So they're starving even when they're fed. This slide highlights this. So this is after a 12-hour overnight fast. in a non-stressed cirrhotic patient. So at rest, you can burn more energy from fat, and they burn double what a non-liver patient would use overnight, and moderate amount of protein. But you can see the energy from carbohydrate, which reflects the glycogen, is down to 2%. That cirrhotic patient is how a healthy control would look after 3 days of fasting. So if we were starting the Atkins diet, we have 2 days worth of glycogen deliberately, because that's how long it takes to make ketones, which is what the brain can use, and then we can survive on, as long as we don't have carbohydrate to flip us back into glucose metabolism. So it takes 3 days for us to look like that cirrhotic patient. They exhibit that after a 12-hour overnight fast. So they're in a permanent picture of starvation. On top of that, we know that a percentage of these patients found years ago, and it stays the same in other studies, to be up to about 30% of patients have this hypermetabolic, hyperdynamic situation with their energy metabolism. So they can burn about 120% or more of their normal energy. That's resting energy expenditure. That's without adding on the factors that we would add. And then that can go up further during periods of infection or decompensation. And stating the obvious is that hypermetabolism is linked to malnutrition. Now, we often can't predict that. We don't know who those patients are going to be. We find that they're the patients where you can just pour nutrition into them and they take a long time to respond, or they're the ones that turn up at an earlier point, more malnourished than you'd expect. Another driver for that is pro-inflammatory cytokines, which are also responsible for the anorexia that patients with liver disease experience. And in the patients that are hypermetabolic, this situation persists post-transplant, so they're the patients that take a lot longer to get back to a normal body weight and may experience more complications because they're malnourished for a longer period of time. And up to 30% is quite a chunk of patients. Insulin resistance, the presence of diabetes, and also the decreased IGF-1, the combination of that contribute to muscle loss. So it's not just the starvation, it's this altered metabolic pattern that influences nutrition and nutrition response as well. So you've got hyperdynamic circulation, you've got increased pro-inflammatory cytokines, you've got altered energy metabolism, you've got the potential for malabsorption from different routes, plus you've got somebody with a poor appetite. Hence why the lady on the first page looks as she does. So as for energy requirements, what do? Well, we use Henry equations and we use an estimated dry body weight. I'll come on to that in a moment with the next slide. So for compensated cirrhotics, we'd use 0 to 20%. Now, the question springs to mind, how do I know whether to use 0%, 10, 15, or 20? This is our clinical judgment based on symptoms that the patients describe. So you might find someone with compensated cirrhosis who says that they haven't lost any weight, they haven't had any changes in appetite, they have no difficulty lasting between breakfast, lunch, tea and supper, and nothing in their life is affected, their strength is fine. You'd think, well, obviously there are no metabolic changes with this cirrhotic patient, and you wouldn't give them a stress factor. However, you do get some patients who say, well, actually, can't open the jars as well as I used to, or I fatigue more quickly, or by 10 o'clock, I feel like I'm turning inside out and I can't wait for lunch. I can't go that long between meals. So you can, from that symptomatic history, you can ascertain that actually there are metabolic changes in that patient. And if you don't intervene, then their muscle will be used. But there might not be overt weight loss because it's quite subtle. But that's how we would assess that. It's not rocket science, it is just based on symptoms. It's different with the decompensated cirrhotics. We have a rule of thumb where anyone who's decompensated gets 30%. And we increase this to, well, whatever it needs to be increased to through the monitoring. So if we're not getting the results we need, we increase what we're giving them. So, but anyone with ascites would get 30%. Anyone who's jaundiced, cirrhotic, losing weight would get 30%. Anyone who's encephalopathic, chronically or acutely, would get 30%. Those that have got multiples of those might need 40%, 45%. Alcoholic hepatitis patients, you can almost give up to 55%. There have been reported increases in their energy expenditure that exceed that. Example, lady on the ward at the moment, alcoholic hepatitis, usual weight 60 to 63. She's currently 70 kilos. She hasn't got any additional fluid. Her BMR with Henry was 1,400 calories. We add on a 50% stress factor, and she's mobile on the ward intermittently, so 25% for that. Looking at 2,500 calories a day, but that seems over what she should have. But that may not be enough. Now, the hospital diet in our hospital is about 1,500 calories a day provision. You can ask for large portions. That might increase you to about 1,800, and the protein's about 60-ish. So even if she eats everything that she's given, which she doesn't feel like doing, but even if she did, she'd still be 1,000 calories down. So it's just an example of how these things can be increased. I suppose the activity factor we would always give, I'll leave the obesity one until I come to the slides. Weight gain, we wouldn't add 500 for weight gain while someone's acutely unwell, but we don't take the stress factor off once the patient's improved. When someone's decompensated, we leave that stress factor because of all the things I've just described to you. All those metabolic changes, they don't go just because they've not got an infection. They've still got ascites. They've still got decompensated liver disease. It just, the energy expenditure might increase during those points. So we would keep, with our decompensated patients that need to improve nutritionally, we would use the stress factor and the activity factor, this is in a non-obese patient, and add 500 calories as a start point. And our monitoring reveals whether or not we're hitting our targets. So it's just to say that these turn out to be really high requirements, and that's on someone 70-odd kilos. You know, a lot of people's dry weight might still be 80 or 90 kilos, but they need the energy that you work out, basically, although it feels too high. So protein. There are changes in protein metabolism. There's an increased breakdown up to 3 times of normal, but there is not a concurrent increase in synthesis. So you can break down up to 3 times the normal amount of protein and not put it back. And that's of the endogenous protein, so that's muscle, essentially, and proteins from other tissues. When we talk about protein, we include albumin simply because the way we look at it is that albumin, we say, is not a marker of malnutrition because it can be affected, you know, I don't have to say it, do I? But those are the reasons. In liver disease, it's ever so slightly different because the way we think about it is that if the albumin is dropping, that's a sign that there isn't enough protein where the liver feels assured that it's got enough to go round to then have enough spare to make albumin. So if someone's albumin's dropping, and particularly if they're reasonably well, then that can be a sign that they're actually protein deplete. So it's not just about muscle. Protein is nails, it's hair, it's skin, it's organs, it's gut, it's membranes. So we think about protein, we think about muscle, but we think about protein as the whole body protein, and albumin is a sort of not sensitive, but it's a reasonable indicator of what's happening. So I saw a guy in clinic, 25, PSC, bilirubin, it was quite yellow, I think it was in the couple of hundreds. He's had to stop working in the last few weeks for increased symptoms of being lightheaded, very tired, very cold. His albumin's dropped from 32 to 27. He does not have any fluid retention. When I did his hand grip, his first reading, and I'll talk about this more later, but as an example, his first reading was 38, second was 34, and his last one was 30. He's protein deplete. You can see that his hand grip fatigued, so he's got no muscle recovery. His albumin is dropping, so he doesn't have sufficient protein in his pool where the liver feels confident that it can make albumin because it's got enough to go around for everything else. And the symptoms that he's feeling are what people feel when they're generating their own energy. So protein requirements are raised because of the increased turnover, but also because they're tapping into their muscle, and we need to put that back. Usual intake, as we know, healthy individual is about 0.7 grams per kilo, increased in the over 60s to 1.2. Compensated cirrhosis, where somebody doesn't exhibit any symptoms of changes in energy metabolism, we'd leave them around 1.2, because there's always that risk they might need a bit more. But if you feel that's much more than they're currently eating, then just match what they're currently eating and monitor them. Decompensated cirrhosis, 1.2 is there because it was in the ESPEN guidelines. Not many of us use that. Anybody who's decompensated, we would always just plump for 1.5. And anybody that needs to gain muscle, we'd use 2 grams as a start point. It can go up from there for reasons I'll come to. So why does that matter? So what? Well, we now know, and we see it more and more, that nutrition is fundamental in the management of liver disease. This is not supportive therapy. This is not just treating weight loss so someone can undergo a transplant. Nutrition is therapeutic in the management of liver disease. You see someone with decompensated cirrhosis, what can be done? You can use diuretics to manage their fluid. You can use lactulose to manage their encephalopathy. You can use antibiotics to treat any infection. You can keep a good grip on renal function. But what can you do in somebody who's obviously not drinking anymore, but in any other diseases, what can you do to change those symptoms? There is no other medical treatment that can be delivered to change symptoms. Nutrition can change symptoms. There are examples in the other talk where we've improved people so they're coming off the liver transplant waiting list because they don't need a transplant at the moment. So likewise, we build people up to get them strong enough to get on the list, but we forget, no, we don't forget, but I think I'm saying don't forget that nutrition can be so instrumental with these patients that we are able to take people off the liver transplanting waiting list. And we are also able to manage symptoms better. So we can manage the symptoms so that they actually reduce. And I'll talk about the symptoms more in the next talk, which is why I'm not elaborating. But we know that patients that are malnourished more likely to have refractory encephalopathy, so in and out of hospital with regular admissions for encephalopathy, more likely to have refractory ascites that requires high volume paracentesis. They're going to be in hospital longer when they do get a problem because they don't have the reserve to fight or recover. And poor nutrition is associated with a progression in liver disease, without a doubt. Post-transplant, the morbidity is higher. More malnourished patients are more likely to return to ITU or stay in there longer in the first place or require a tracheostomy, more likely to be susceptible to poor wound healing and infective complications, which can be said for any surgical population. And with the challenges with the donor pool, we need people that can be able to receive their donor liver and get the most from it. We don't want someone that we can predict is going to languish in ITU for 3 to 4 weeks and potentially not recover from that. It does happen because there are always unforeseen problems. However, if we can predict it, we shouldn't be going down that route until the patient's in a much better position. So, assessment, anthropometry. We live and breathe hand grips and mid-arm muscle circumference. We do use weight. In your non-fluid overloaded patients, obviously, weight is great. I find it difficult now, being so used to doing anthropometry, to actually just take weight as a single index of nutritional assessment, because there's still that question, well, what's fat and what's muscle? However, we use the dry weight that we'd you just get quite good at this, but the post-paracentesis weight is a good one. We don't, or centres rarely drain to dryness anymore. So there's always a bit of residual fluid in the abdomen, a few litres maybe, but the patient can usually tell you how their stomach feels compared to how it used to feel. So you can subtract the volume drained, which could be 8, 10, 12, 14 litres, or as little as 4 or 5, plus a bit remaining from their weight. Edema is more difficult to assess. There is a guide in the Penge group, but we see edema that's far more significant. So severe edema in the liver patients, where someone is, up to their waist with edema, enormous legs, can be 10 kilos a leg. And that's, we had a lady like that the other day. She had 20 kilos of edema up to her waist. Very interestingly, just as an aside, poor protein status is going to contribute to that. And when you feed people consistently protein to meet their requirements, you can actually help shift that edema as part of this poor protein status. So we would estimate the weight of edema, looking back at usual weight, what they feel they've lost, where they are now, and what fluid they've got. And it's not an exact science, and you just need to get a ballpark figure. If we overestimated someone's requirements, does it matter? If they went home and decided to eat an extra meal, we wouldn't be worried. So if it's only a few hundred calories, it's not important. Hand grip is a great, non-invasive, quick, easy to reproduce method of assessing function. And one of our surgeons said with the anthropometry that we've taken something innocuous to a surgeon, like nutrition, which is a bit airy-fairy with no real figures, and made it tangible. So we've put figures on people and things and function and what they can do, and made it understandable. And I think as a profession, it really improves our credibility and our role, and the link back to science, because I think that gets forgotten quite frequently. So hand grip in liver patients correlates really well with morbidity and mortality and the things listed on the slide, and it does improve with increased intake. So we would use this weekly as a minimum. We might even do twice weekly on inpatients, but weekly definitely to assess response to treatment. Because the first thing, as you know, when you refeed somebody, I don't mean refeeding syndrome, I mean just when you're feeding somebody up and meeting their nutritional requirements, they don't gain weight straight off, do they? The first thing is the power. So they come into hospital, they can't lift the water jug, they need 2 to mobilise to the toilet, they're walking with a frame. But then, before they've put on an ounce, you see that they can lift their water jug, or they can get out of bed with the help of one and mobilise independently, or with a stick. That's all to do with muscle power. And as soon as you stop the muscle being catabolised, you get that return of power. And hand grip shows it. This is the reference range, just to say that there are different types of hand grip. We use that Takei, T-A-K-E-I. That's the one we use, and that's the reference range associated. There's one beginning with K, I can never remember the name of it, sorry, that's different, and I think that is the reference range that's now in the Pen Group book. So just be careful with what you're using and which reference range that you're using, and that it's the right one. Mid-arm muscle circumference. We work out from mid-arm circumference and tricep skin fold. A lot of dietitians, I think, worry about doing tricep skin fold for fear of causing injury or pinching. But compared to what people have done in hospital, it's relatively minor. We don't sort of cannulate people or do central lines or venipuncture or arterial line. All of those things are terribly potentially painful. This is a very non-invasive procedure. It's not really a procedure. Assessment. And people love knowing about themselves. It really brings home the message of what they've got, what they need, and how to get it. So There's more error in the larger patients. So in the obese patient, you're looking at 3 to 5 millimeters error of the tricep skin fold, which can affect the muscle. But in thin patients, it is dead easy because there's not much to measure, and the fat moves away very easily because a lot of it's gone. So practicing on your malnourished patients can get your confidence up to be able to be more accurate with the less malnourished patients. So we always use the right arm. That's the other thing to say. People often do non-dominant, but the reference ranges used use right arm. Apart from the elderly reference ranges above the 75s, if you're using those, that's left arm. So Gwen, just be careful what you're using to interpret the results. We have different ways of interpreting these now, just thinking outside the box a little bit. This is the theory, and it still applies. We know that mid-arm muscle mass actually correlates with body cell depletion. So the MAMC on the top of the right arm has a good correlation with overall body cell mass. So that is a good link. And the hand grip correlates quite well with MAMC. So we've got strong links to work with there. The reference ranges don't always represent our current population, but what they're good for is looking at proportions and doing serial measurements to track muscle. So the way we describe it to people is we do a sort of scale of 0 to 100 to represent the centiles, and we say they don't have to be 100%. If they're 50%, then they're average build. If their fat pinch is on the 75th percentile, then they might be slightly better made. Choose your words carefully. And then if they're on the 25th, they could be naturally slim. But we plot the mid-arm circumference. So we would just do a 0 to 100, put the build as the mid-arm circumference, then put the tricep skin fold, and then the muscle. And what I've just represented is usually what you see. So the build and the tricep skin fold tend to be, or the build can be reduced if they've lost weight, but the tricep skin fold will be preserved and the muscle will be down here. So you either see some weight loss, and the fat mass matches that and the muscle's here, or you see a build in the middle of the chart with a low muscle and the fat's still up here. And that really highlights to people that they're targeting their muscle and that they can't use their fat. And it's enlightening for us too, because you can see someone that's 80, 90 kilos, they might look fine. You know, they might not report many changes. I saw a NASH cirrhotic patient the other day. His build was the 90th centile, his tricep skin fold was the 95th, but his muscle was the 75th. It's good, but it's not on a par with the others anymore, and his hand grip was low. So it's not just, you can't say that somebody's fine if they're over the 25th centile anymore with the difference in the size of people that we're measuring. It's the rate of muscle loss. That person, he'd lost that in a month. He was profoundly weak, but his muscle's still on the 75th centile. So it's about how to interpret, thinking outside the box and looking at the relationship of those different measurements. Again, we get other information. So you might have a low muscle mass and think, well, why are they under the 5th, but their hand grip is 38? You know, that just shouldn't be. But when you talk to them, they might say, well, I've been losing weight for months. It was really, really rapid, but my appetite's just come back since I had paracentesis or started diuretics. So they've got recovered muscle function. So they were on the decline, but they're now meeting their requirements. So they've had the return of power. So they're still severely malnourished, but they've got that return of power. Alternatively, you might see someone who's got low muscle mass and a very poor hand grip, and it shows they're still doing this. You might have somebody that has very good muscle mass, as the chap I just described. It could be 50th, 75th centile, but their hand grip could be early 20s for men. It could be early teens for women. That shows declining function despite them having a good muscle mass. So it's not the actual mass anymore, it's what's happening to it. This is a SGA that the Royal Free produced, which formalises what I've said a little bit. We don't use this. We probably have this as a blueprint in our brain anyway, the way that we assess people and assign risk. But that's available and published work. So we assign a risk from the point of view that the examples I just gave you back here, that first patient, he's severely malnourished, but he might now be moderate risk because he's halted the muscle loss and you're starting to turn it around. The next patient is severely malnourished but high risk. The next patient is moderately malnourished but high risk because they're still losing muscle. So you can assess whether they're deteriorating or improving. So that would be the low risk or the high risk. And then you can attach that to the amount of muscle they have, whether it's severe, whether it's mild muscle loss. So we tried to get some additional arms to defining sarcopenia or nutritionally at risk patients and malnutrition. And the consultant and I came up with this list sort of to be fine-tuned, but we were trying to just sort of use a range of parameters. So it's not just about what's happening to hand grip. It's not just about what they weigh. You might have somebody with a BMI of 35, but they're eating 50% of their requirements. Then they're at great risk because they soon weigh a lot less and they're going to be using their muscle. So we came up with this grip strength of 15 or less, regardless of gender, is really severely functionally compromised. You do get exceptions with patients with arthritis, or they say, I've never been strong, and you need to look at other more subjective measures of their function, like how far they can walk, what could they do, what can they do with regard to day-to-day activity. Dry BMI less than 20, it's sort of undisputable with the evidence that you've got higher mortality. Mid-arm muscle circumference less than the fifth, absolutely, definitely severely malnourished. But this additional compromising of oral intake. Obesity and liver disease. Anthropometry is challenging. Hand grip is excellent because that's independent of arm size. So you can get a good idea of what's happening with their muscle. If you can't do a tricep skin fold, do a mid-arm circumference. It can still help you track changes in weight, particularly where there's fluid in lower limbs or ascites. Requirements. When somebody is, if someone has, there are two arms to this. There's people with fatty liver, but there's also people with other liver diseases that are more obese. So if they are acutely unwell, we would feed to BMR plus a stress factor. We wouldn't use the activity. So that's when they're acutely unwell in hospital with something. For non-stressed patients that fall into either of those categories, you could just use the BMR. If they're in hospital with something else or they're recovering, you could feed to BMR. If they are not in hospital and they're as fit and well as you can be with sort of fatty liver disease or another liver disease, then we do a lot of calorie matching. So we wouldn't calculate energy requirements because they don't always fit with what the person does. So we take a history, 7-day one if we can, with a food diary and fatty liver clinic, but in others we just do a history like you would with anybody else, and we calorie match. But we might redistribute, because the key thing with these patients is that they need nutrition every 2 to 3 hours to preserve their muscle. And protein supplementation is essential. So in that group, we would prioritise the protein, and if they're overfed calories, if you were feeding them, we'd go with that, because you need to hit the mark with the protein. We can maybe pick this up in questions. So oral nutritional supplements, yes, we'll talk about them later on. Absolutely, definitely. It's rare not to, unless someone's compensated and they've got a good appetite. Important thing is have a low threshold for enteral feeding. If you've got somebody that isn't eating very well, they're decompensated, they're already malnourished, they're losing muscle, lost muscle, even if they've got good function, they're taking a couple of supplements, eating what they can, what's clinically going to change for that patient to make them put on weight? Unless they are overtly septic and antibiotics is going to improve them, then that might improve their eating. If they're going to be paracentised and then suddenly they can eat more, that might improve them. But unless it's something tangible like that, what clinically is going to change for that patient to consistently meet their energy and protein requirements? And the answer is nothing, really. That's how it's going to stay. You might add another supplement that they maybe take, they maybe don't. If there's any doubt, feed them. We do loads of home feeding now, and we have a very low threshold for nasogastric or nasojeginal. Can't use PEGs, can't use jejunostomies, because if they're acidic, they'll leak, but also you get a lot of altered vessels and collateral circulation across the abdomen, so you can't have those procedures, because if you pierce one and the liver, the blood's not clotting, then people will bleed to death. So bedtime snack, essential. 50-gram carbohydrate snack before bed can be moderated for those that are obese, turned into healthy eating choices, and reduced to maybe 30 grams of carbohydrate. But that 50 grams of carbohydrate before bed is invaluable. It's basically giving the liver something to burn so that it doesn't take from the muscle. So the muscle is preserved, and they get laying down of protein tissue across the body, and an increase in sort of retention of nitrogen. These are some examples. There are lots of examples in the liver diet sheets that are available. I'll skip over this. It's just to say that there is benefit to giving protein in dollops. So if you give less than 15 grams, you get less synthesis of muscle tissue. But if you give 25 to 30, that's optimal. Sometimes that's doable, sometimes that's not. It's fine-tuning. But if someone can have up to 30 grams of protein with their main meals, then that's great. You might even couple the meal with a supplement to stimulate synthesis of lean tissue. So practical considerations in patients with liver disease. You need to benchmark where they're at. So early identification through liaising with the screening, the nursing staff, consultants, medical colleagues, obviously our teams, heightening education and awareness around the consequences and the fact that a lot of this is seen as irreversible with liver disease. It is not. It is reversible. So you can make dramatic improvement. So early identification, spreading the word, benchmarking your patient with regard to hand grip, anthropometry, what you've got available to you. Overall aim is to meet energy and protein requirements daily. That's what we strive to do, hitting the targets on a daily basis. If you do, you will spare the muscle. If you spare the muscle, the liver doesn't have to generate energy to feed the patient. It doesn't have to do extra work. It can focus on the tasks in hand and improve its function. Maximise oral intake, minimise restrictions that are not appropriate, improve the meal pattern, so people need sort of breakfast, mid-morning, lunch, mid-afternoon, evening meal, supper. If they're up overnight, have a supplement, break the fast. But it will not work unless you do that, because they might gain muscle, but they will never get proper return of power if they're always dipping into their muscle to feed them. Oral supplementation, we'll talk about products later, but high protein supplements. It's difficult to get anywhere with the usual 300 calorie 12 grams because you might have a 50, 60 gram protein deficit. If someone's in hospital, they eat their meals, 60 grams of protein. If you think an 80 kilo person, 1.5 grams, they need 120. We feed them that. If they need twice that, we've got someone at the moment between 130 and 160 grams of protein a day, because they're a decent-sized person, but they're losing muscle. So we feed them to their high requirements. And a low threshold for enteral support or total supportive nutrition. So thank you. I hope that was useful.